Sorry. Hopefully the MPH wasn't too bad for you. Survived it. For our lab next week, which will be, I believe, Wednesday morning, we'll break up into 3 groups. I'll have 2 additional faculty kind of helping me. CMP is going to be meeting in 2205, so we're not going to have access to that lab, unfortunately. So we'll be in like the 2206, 2207, and then up here. So we're going to have to, unfortunately, do some walking. But you'll have one topic that will be, or one section that will be about hypertension and hypertension management. You have another one that will be about ischemic heart disease, ACS, how to respond to those types of things. And then you'll meet with me to do the atherosclerosis management part to it. So we'll work on walking through a clinical scenario with the algorithm and coming up with the correct answer. And for the exam, I will give you the algorithm to reference. So please don't spend all your time trying to memorize the algorithm, because I'm going to give that to you. What I'd rather have you do is just practice working through the algorithm so you understand how to get to the correct answer, because I will ask maybe some caveat type questions. So high risk, high risk patients may need to be on a higher stat versus the moderate dose and those kind of things. So just practice while you're studying, working through those scenarios. We'll have the opportunity to work on it together during that lab. So, and then Tuesday, on the schedule it says I have 2 2-hour blocks with you, but because I switched with Colonel Rogers on Monday, he'll be teaching the 08 block for you for that neuro lecture, and then I will come on at 10. And that will be our virtual day, so don't come to school on Monday. It'll be all done virtually, because I think there's a planned power outage on days or something like that. So don't come to class Monday. Questions about that? Okay. All right. So we talked yesterday about the arterial and the aortic side of the vascular diseases. Today we're going to talk about the venous side of it, because this is probably maybe a lot more common issue that you're going to encounter in your primary care clinics. Okay. So this is an important topic for us to discuss. There's a number of venous diseases that we need to talk about according to the PANCE blueprint. But again, this isn't in an exhaustive list of venous diseases that you may encounter actually in clinical practice. So please don't think that this is all you're going to see. It's just this is what's required of you to pass the PANCE successfully. So we're going to start first by talking about deep vein thrombosis, so DVT. So the name, it tells you what it is. So it's a thrombosis, so it's a clot that happens to be in the deep veins. So you have deep veins and you have superficial veins, right? The concern with the deep side of this is this tends to have a lot more direct access to the heart. So that's why we become very concerned about DVTs, is because there is that direct access. So that means we can have more morbidity associated with a DVT, because it can cause more problems because it can get access to vital structures. Okay? So what might make somebody at risk of developing DVTs? Well, we always talk about age. Age is a risk factor for like every disease, right? But it could be an acute infectious process where now this is adding like an additional stressor to the body, and that's going to kind of set off this cascade to form clots. Okay, so infectious processes can do it. Cancer, because you're releasing all of these factors because of the cancer. Fractures, especially like lower extremity orthopedic fractures, cause this not only because of the immobilization associated with these fractures, there's also all these additional chemical factors that are released with these long bone fractures in the lower extremities that lead to a pro-thrombotic kind of state. Okay. So yes, the immobilization is a concern, but it also, there's some other factors that put folks at increased risk of developing clots. And the biggest thing, and the reason we are concerned about DVTs, is if you leave it untreated, it will go to the lungs, or could go to the lungs, and cause a pulmonary embolism. So why do these clots form in the first place? Well, Virchow's triad is used to kind of create that environment that leads or pretends to somebody who would be higher risk of developing these types of clots. And Virchow's triad says, first thing you have to have is venous stasis. So this could be immobilization, like we talked about the long bone fractures. This could be immobilization for a long flight. When I was in Guam, had a number of healthy active duty folks who went home for the holidays, who jumped on that 15-hour flight and came in to me a week later with a blood clot. That could be an immobilization. That could include like long car rides. If you ever had your grandparents tell you it and stop every 2 hours to walk around when they're on a car ride, this is why, because they want to decrease that chance of forming the clot because of that prolonged immobilization. There also has to be some kind of endothelial damage. Because remember, the endothelium has those pro-thrombotic, anti-thrombotic factors, and when there is a damage, it will elicit the expression of these pro-thrombotic factors, leading to the clot to form, because it's trying to heal, right? So there's got to be some kind of endothelial damage for that clot to form. And then there has to be a hypercoagulability, which there's a number of things you're going to talk about next semester with HEMONC, as far as things that might portend to you developing clots or being at higher risk of forming clots. But there are other things that can lead to this, and this could be acquired to like your sepsis, those kinds of things. When you talk about DVTs, typically the lower extremity is much more common to experience these DVTs versus the upper extremity. It does happen in the upper extremity, but usually there's some cause, like there's an IV or there's a fracture to the arm and it's immobilized in a cast for an extended period of time. Those are common, or those are causes of an upper extremity. But lower extremity blood clots, DVTs, are much more common, and whenever you encounter a patient with a pulmonary embolism or a complication of a DVT, be thinking that it came from the lower extremity. But when we talk about lower extremity DVTs, we have to talk about whether it's a distal, meaning like it's in the calf or below, or proximal, where it's like above the knee. Because when we talk about the management, we are going to become a lot more concerned if it's a proximal vein deep venous thrombosis, because these have a much higher risk of breaking off and getting sent up to the lungs compared to the distal ones. Okay, there's a little more movement and finagling to get around and up to the heart if it's in the deep, it's in the distal or calf veins. When you encounter a patient with a DVT, what could you see? So typically you're going to have that unilateral extremity swelling. So we talked about, like, from a heart failure, you get bilateral edema. With a DVT, it's going to most likely be unilateral because if that clot is in my calf on my right leg, it's not going to affect the blood flow of the calf in the left leg, right? So that's why you're going to see that unilateral or unilaterality of this disease if you have two of the areas that are affected. You can get kind of some little redness that you might see. You may actually even be able to palpate this venous cord because of that clot being there, causing like that backup of blood flow from the distal area up to the proximal. And then, of course, they always teach us in physical exam classes about Hohmann's sign, which is not a great test. Don't be falsely reassured if you do Hohmann's and it's negative. You're like, oh, no, it can't be a DVT. It has a high false negative rate. So, but you can see homicide positive in folks with a DVT. But this example, this picture here, is a great example of what you might see. It doesn't look significantly different, but there is a difference between the right and the left leg. I see a little more kind of venous, almost varicosities here on the patient's left. It looks thinner to me, it looks paler than it is on the right, where it looks like, hey, I'm a little swollen here, like the malleoli are a little obscured because of that swelling. I'm not really seeing the same kind of varicosities on this leg, which just shows that this is probably more edematous than the other leg. But recall that you have to have a differential diagnosis anytime you encounter a chief complaint. And a differential for somebody with a DVT could be something like a muscle strain or tear. One thing that I have seen in clinical practice is like a popliteus tear. Looks like a DVT. It's unilateral, swelling, pain, calf flexion. Homans is positive. All this, thinking that it's a DVT. We do the testing for it. It's negative, and then you're left scratching your head. Well, what is this? And it turns out it was just the popliteus muscle tear, at least in that patient. So muscle tears, strains. There could be, we'll talk about lymphangitis, lymphatic obstruction. It could even be a ruptured popliteal cyst. It could be other things leading to this. So how can we try to help differentiate those folks who have a DVT from those who have an alternative diagnosis? One objective scoring tool you can use is Wells criteria. You're going to hear a lot of calculators. We've done a lot of calculators already in this block, and I will continue to kind of throw calculators out there. And all of these are in the MD Calc app that's free that you can download. So that is a great resource to help you get some objective data to help with medical decision making. But what Wells criteria, or a Wells score, says is you're going to answer the questions in the calculator, and then it's going to spit out a number. And if it says you have a low probability Wells, then do a D-dimer. If the D-dimer is negative, you're done. DVT is ruled out. So do not need any further testing whatsoever. If you have a moderate or high probability Wells score, then get a compression ultrasound done. So you'll send them to radiology. You'll even will learn them from a POCUS class, the point of care ultrasound class. You'll learn how to do DVT testing. But get an official ultrasound looking for a clot. If it's negative, if the ultrasound is negative, get a D-dimer. If the D-dimer and the ultrasound are negative, great, you've ruled out your DVT. If the D-dimer is positive, then you're going to repeat the ultrasound in 1 week. Because the D-dimer, although not a great test, and not a specific test, tells you that something's got to be going on. Some process is involved that could lead to clot formation. So with Wells score, if you're low probability, D-dimer's negative, you're done. You've ruled out DVT. If you have a moderate or high probability Wells score, get the ultrasound. If ultrasound's positive, great, you know your diagnosis, go ahead and treat. If ultrasound is negative and D-dimer is negative, you've ruled it out. If it's D-dimer is positive with a negative ultrasound, repeat 1 week. And when we start the treatment for DVT, we are not giving thrombolytics necessarily. As long as the patient is stable, we're not giving the big guns to try to break up that clot, similar to what we did with like the peripheral arterial disease, where we had that acute thromboembolism, right? We're not giving those thrombolytics to break up that clot. But what we are doing is, I don't want that clot to get any bigger. So I'm going to have them on a anticoagulant to prevent that clot from getting bigger. I'm trying to afford the time of our natural clot break chemicals and systems to go in and break up that clot that formed already. Then the other reason, the other goal that I have is I want to prevent that clot from breaking out and going up into the lungs and causing pulmonary issues. So let's prevent that acute pulmonary embolism, and then let's prevent some complications that may develop because of that clot being there. Things like chronic venous insufficiency, which we're going to talk about, that is a chronic complication from a clot, and that can be pretty disabling and uncomfortable for our patients. So what do we have at our disposal then if we're not doing thrombolytics to treat this? Well, the preferred agent is going to be now your direct oral factor Xa inhibitors, so your DOACs. These work great. Patients tolerate these pretty well. And they don't have to come back for frequent monitoring. They're not having to give shots to themselves necessarily. So these are pretty well tolerated medications that can be used to treat these people. The one problem though is your patient has a prosthetic valve. You cannot use this medication. Okay. So just remember that caveat in treating patients with a DOAC. If they have a prosthetic valve, you cannot use this medication. Low molecular weight heparins, so like your enoxaparin, they work great at preventing the progression of the clots. The only downside is injections. So can your patient give you provide themselves injections on a twice-a-day basis? Warfarin or Coumadin used to be our mainstay to treat this. Poorly tolerated, very difficult to manage, very difficult to keep patients in the therapeutic range when you look at like their INRs, to the point where, you know, just something they eat, Thanksgiving's coming up, they eat a large load of vitamin K, and now their therapeutics on this just go out the window, and it becomes very difficult. Usually these patients are coming back every other day for blood tests. Their arms just look all purple just from all the trauma from getting stuck all the time and bleeding into the soft tissue. So patients don't tolerate warfarin very well. So that's why we have the other agents, and that's why those other agents are preferred over warfarin. But if they do have a prosthetic valve, then unfortunately, you're kind of stuck having to do this for their anticoagulation. Well, let's say you have a patient who can't tolerate anticoagulation at all. So this would be like your elderly patient who falls frequently. Do I want to have them on an anticoagulant and they fall, hit their head, and now they have an intracranial bleed? So what could we do to help them prevent or decrease that risk of developing a pulmonary embolism? That's where they came up with these inferior vena cava, IVC filters, where it's just like this little cage that camps out or is placed in the inferior vena cava and just kind of sits there and hopefully will catch any clot that kind of breaks off and gets sent up into the vena cava. So it kind of collects it before it gets to the heart. It's not a 100% solution. You can imagine, especially smaller clots can break through that cage and get to the heart. But this will prevent that large clot from getting up to the heart. Some complications I want to talk to first before we look at our treatment algorithms is two things. So the first one is this phlegmasia alba dolens. And it's called like a milk leg, where you just kind of get this kind of really significant pallor. But you can look at the different legs, and this is pretty edematous compared to the unaffected leg. But this is due to when you have a 100% occlusion of the deep vein, and now the drainage out of that extremity is all reliant on the superficial venous system. So you're still getting that venous drainage occurring from it, but the deep veins are 100% occluded, and there is no blood flow getting from that extremity up to the heart through the deep veins. Compare that to phlegmasia ceruleus dolens, where now this is an emergency because not only are the deep veins occluded, but now you also have the superficial veins that are completely occluded, and this just looks like a very angry leg, right? Part of the complication of this, which makes this a limb emergency, is that swelling from the occlusion can lead to then affecting the arterial system, leading to compartment syndrome, which then leads to critical limb ischemia, and if not caught and treated quickly enough, could lead to the limb being amputated. So this is a vascular emergency if you see this with your patient and their DVT. So I wanted to walk through kind of the algorithms. And remember when we talked about how you have proximal and you have distal DVTs, this is why it's important to be able to differentiate where that clot actually is. Because when I have a proximal DVT, I'm going to look for any evidence of critical limb ischemia, to include the ceruleus dolens that we just showed. And then if I see that, I am going to be super aggressive in treating this. I'm going to do a surgical procedure if I can to do a surgical thrombectomy followed by IVC placement. So that's what you're going to be. That's what you're going to do if you see that critical limb ischemia present with a proximal DVT. If I don't see that, but the concern is that with this proximal DVT, you have an increased risk of developing a pulmonary embolism, I am going to try and treat them with 3 months of anticoagulants, the DOACs, if there is no contraindication for anticoagulation. Okay. If there is a contraindication, then I'm stuck with doing an IVC filter. But ideally, I want to have that patient on at least 3 months of anticoagulation for a proximal DVT. Now look at the distal DVT. So we said that this version has a lower risk of pulmonary embolism. And when you look at the algorithm, it looks complicated, but the question is, does the patient have symptoms? The answer is yes. Go ahead, and if there's no contraindication to anticoagulation, go ahead and anticoagulate for 3 months. If the answer is no, they're not having symptoms because of this distal DVT, then basically it has you answer a bunch of questions. And let's just assume all of those questions are no, then I can actually just do watchful waiting and just regular follow-up. So there's an avenue for us to not have to treat this and just let the body's natural processes work to break that clot up. Okay? It doesn't mean that 100% of your patients with a distal DVT are going to be watchful wait. It just means in a select group, we may be able to just watchful wait and not put them on the anticoagulation, not have to subject them to the side effects and the bleeding risks and all those types of things if they were to have this distal DVT. So we can be less aggressive in treatment for a distal DVT. Questions about DVT before we move on to the next topic? Yeah.
I just have a question about the IVC filter.
Yeah.
Is that like something where they just thread it into the vein, or do you have to have like a surgically implanted?
So they will put catheters through the vein, usually like the femoral vein, thread it up into the inferior vena cava, typically below the renal veins where they come into the inferior vena cava, and then place it. Yeah. And then, so that's typically how they'll place it. But it's catheter placed, not like an open procedure or anything like that. Okay. Any other questions?
If they do catch a handful of clots, we'll say, like, can we expect the body to break those down relatively quickly, or is it just patient dependent?
Patient dependent, because I think it also depends on what's going on. Like when we talk about Virchow's triad, that process that led to that clot formation, say they are severely sick, septic, or whatever, if that condition continues even after they have the IVC placed, filter placed, then that may delay your body's natural ability to break those clots up. So it kind of depends. But the biggest thing is it's hopefully preventing that large clot from breaking off and getting into the lungs and causing a massive pulmonary embolism, leading to heart strain, heart failure, pulmonary failure, all those other complications associated with that. Yeah. All right.
Could that include the IVC?
It's possible, yes. So it is possible. Have I seen that happen? No, but it is possible for it to include the IVC, and then you may have to bring the patient back to do a surgical thrombectomy at that point. Okay, so let's now move on to from the deep veins, and now let's look at the superficial veins and what we might encounter with that. So superficial thrombophlebitis, typically in the vast majority of our patients, is a benign disorder that typically doesn't require a lot of treatment for it. Usually it's just kind of a conservative management, conservative treatment, and this condition will go away on its own. Typically, what you'll see in our hospitalized patients who develop this is they have an IV placed, and maybe we left it in a little too long. It forms a clot and triggers this condition to develop. That's probably the most common cause that you'll see for this condition. When you look at somebody with superficial thrombophlebitis, itis inflammation, right? It's going to look like maybe there's a cellulitis in there, maybe something else is kind of going on. You get the streaky look to it and everything like that. You may become very concerned about this, but antibiotics are not going to really do anything for this condition because it's not a true infection. Okay? So, how are we going to try to diagnose this condition and rule out maybe other things on our differential? So, if there's known risk factors and they have a palpable vein, maybe we just don't do anything, we just do the conservative treatment and that's it. But if you still are wondering and you are concerned, then go ahead and do a Doppler ultrasound and look for that evidence of that clot being there. If it is, great, now you can treat it. If it starts to extend, then we may need to do some further treatments and stuff like that, but the Doppler ultrasound can help you with the diagnosis of this, if you're questioning. Now, when we talk about conservative management, what does that really mean? Well, let's do bed rest. Let's elevate the affected limb. So usually if we say it's an IV, it's usually an upper extremity that's the problem. So they'll just prop it up on a pillow or whatever while they're sitting in their hospital bed. You can put warm compresses or heat on it, and then compression to prevent that clot from getting kind of bigger. Let's compress it and stuff. And then, of course, there is going to be pain associated with this. So let's manage that pain with like an anti-inflammatory and make them comfortable. Most of the time, that's all you need to do. But if this lingers for an extended period of time, so greater than 2 weeks, it starts to progress and it gets bigger. Now it starts to get infected, so there's complications developing because of this superficial clot in the vein. Then we may need to do a surgery to go in and actually remove that clot. But the vast majority of cases will respond to conservative management and treatment. Let's now move on to varicose veins, which is something you're going to commonly see in your clinics. This is a pretty bad example of varicose veins. This patient does not look like they're comfortable, but varicose veins, just as a broad definition, is basically the veins are tortuous, they're distended, they're kind of filled with all this extra blood, and there's not a normal flow of blood back up to the right side of the heart. And it can affect really any extremity, but the lower extremities are super common. It could also affect like the esophagus. We call those esophageal varices. It could affect the rectum, and those are called hemorrhoids. Pregnant women it may affect the vulva, so now you're having labial varices and very uncomfortable. So it can really happen in lots of different areas, but we have different terms depending on the area that it is. But ultimately, it's just varicose veins. Okay. What tends to put folks at risk of developing this? Well, unfortunately, female gender is a risk, especially during pregnancy or even postpartum. Folks who have jobs where you are doing prolonged standing or even prolonged sitting, i.e. all of you right now. Obesity. Obesity because of the extra abdominal fat and mass interferes with that normal flow of blood back up from the lower extremities and into the heart. So that will cause that blood to kind of accumulate and stay in the lower extremities, causing that tortuous dilation of your veins. So how are they going to present to you? Well, one is you're going to see it, okay? If it's kind of subtle and they're like sitting or laying on the exam table, have them stand up for a period of time while you're talking to them and see what happens, see what changes, okay? Because that standing is going to put them at risk of having this, and they become more apparent if you do that. Most of the time, we just think of this as a cosmetic concern. They're asymptomatic from it. They just don't like the look of this. I mean, imagine if your leg looked like this, right? But it doesn't cause any problems. It's not necessarily causing DVTs, it's not causing pain and all that kind of stuff. They just don't like the look of it. Unfortunately, most insurance companies, including TRICARE, will not pay for treatment if it's asymptomatic. But if they have pain, now it's symptomatic, and now most insurance companies, including TRICARE, will pay for it. So when you're advocating for your patients and they look like this, and you're like, that must be awful, they've got pain associated with their varicose veins. And then TRICARE will cover it. You'll be able to refer them to the vascular surgeons, and they'll take care of it. Okay. But most insurance companies, if it is a cosmetic only, will not pay for treatment. Because typically what we do to treat these is conservative stuff. So let's elevate the legs as much as you can. So that's something you can do in your seats right now. Trying just to kind of prop them up a little bit. Granted, I don't want you necessarily putting your legs above the level of your heart, because you may fall asleep. Elastic compression stockings. You can prescribe those to your patients. Basically, they get a prescription. They'll go to, I'm blanking on the medical supply store in the exchange right now, but they'll bring it there. They'll get whatever you ordered, and then they'll be able to wear these. Give them a couple of pairs. They start to smell pretty gross. Exercise. So they got to be moving. Because remember, the process of bringing blood up through the venous system is not an active process. There's not a pulse to your vein. It's kind of a passive process to do that. So you have to use like the muscles around to kind of get that blood circulating. So get that patient up, get that patient exercising, moving, those kinds of things to get that blood out and back up to the heart. Part of the process with this is you're going to start to see some skin breakdown, which may put them at risk of developing like cellulitis and those types of things. So there's going to be a skin routine that they have to do, which will decrease their risk and chances of having skin infections develop. So let's put topical barriers like Vaseline or Aquaphor, those kinds of things on the skin. Maybe they're going to need some topical corticosteroids as well, decreased risk of inflammation. If they start developing ulcers, then we're going to have to be a little more aggressive in our management or treatment to manage those ulcers so they don't have this infection taking hold and leading to a much worse condition, including like sepsis. If the conservative treatments are not working or they're symptomatic, Then what we can do to fix this is they can go and the vascular surgeons can basically tie off the superficial vein so that now all that blood flow has to go through the deep venous system and return the blood that way. So you're getting rid of basically the superficial vein system. They could put a laser into the vein and then burn it and get rid of it. They may even be able to do some injections to kind of get rid of like those superficial veins, especially if they're like the smaller veins, get rid of those. So there's a couple of different things that we can do that are technically surgical options that can fix this and make our patients more comfortable with their varicose veins. Okay, questions about varicose veins? So again, your patients are symptomatic from their varicose veins if you want to refer them to a vascular surgeon to get this taken care of. All right, so we talked about one of the complications of a DVT is chronic venous insufficiency because you have that disruption of blood over a chronic period of time leading to the development of this condition, chronic venous insufficiency, where basically that blood flow back up through the vein is affected, and because of incompetence of the valves inside of the veins, instead of having that one direction flow, it may come up and then go right back down if the pressure is not there to keep it moving upwards. And the problem is because this is a chronic problem, there's going to be chronic changes associated with this. And here's just a couple of things that it could lead to, or things that can actually lead to the development of this disease. Well, you can see patients who have this are typically going to complain about just legs just feeling heavy, not feeling like you really can move around too much. This sensation gets worse when they're standing for a prolonged period of time, or if they sit for a prolonged period of time. And you may start to see some of these chronic changes where like the skin starts to get hyperpigmented, you start to get this stasis dermatitis, flaky kind of look to it. You may start to get ulcerations developing from this. So there's a lot of long-term chronic changes that occur that can lead to other morbidity conditions. Typically, what you try to have folks do with this is, if the problem is that blood flow is just sitting there, get them up, moving around, elevate the legs to help take some of the gravity's effect off of that blood flow and try to get that blood flow returning and sent back up to the heart. Now, one of the differentials for this is actually what we talked about yesterday, which is that like that peripheral atherosclerotic vascular disease, arterial atherosclerotic vascular disease. So you've got to look to make sure that this is not an arterial problem. You're going to manage an arterial problem very differently than if it's a venous problem. So let's do an ultrasound and let's see if the arteries look bad or if it is just a venous problem. Let's do the ankle brachial index that we talked about yesterday and see what our AVIs are and rule out the peripheral arterial disease. Okay. Then once you have confirmed that this is just chronic venous insufficiency, then do the conservative treatments, have them exercise, have them elevate their legs, have them put the compression stockings to try to help with that blood flow, bring the blood back up to the heart from the legs, and then avoiding prolonged standing or sitting. So these are the folks who may, if they have a desk job, maybe having to get like a Varidesk where they're having to go up and down, up and down, up and down during the course of their day. Then, because of all these skin changes that can happen and occur with this condition, there's got to be a skincare routine to help prevent the additional morbidity with this. So doing, washing, of course, having good hygiene is important. Emollients after showering and bathing, topical barriers, so you're not having that breakdown, you're not having like little trauma leading to more serious issues because that skin is so fragile because of that disrupted blood flow. And then of course if they get ulcers, then we have to start managing those ulcers because that can lead to them getting even more sick, such as sepsis, from that infection kind of gaining access, getting through that protective skin barrier, and then gaining access to the bloodstream. Questions about venous stuff before we move on to the lymphatics? Okay. So we're going to finish up with lymphedema. So lymphedema is basically an obstruction of the lymphatic system. So that flow in the lymphatic system is disrupted. So basically you have downstream effects from it where that lymph kind of just accumulates and stays into the soft tissues and doesn't come back up to the heart where it needs to help circulate it. You can get primary causes, which is like a genetic thing, but the secondary causes are the most common encounters we're going to have with this. In the world, the most common is a parasite called filariasis that gets access to the lymphatic system and then basically hangs out there and disrupts the flow of lymph through the lymphatic system. And now you get that swelling and everything like that. This would be like your elephantitis kind of pictures. Okay? Other things though, and in the US and other industrialized nations, typically we're thinking of like radiation or surgical treatments that cause this. Kind of a great example of this is breast cancer. As part of like the mastectomy of the surgery, is we'll do a sentinel node biopsy where we'll inject a blue dye, see where that sentinel node is, and then we'll biopsy it to see if cancer is in that node. If it is, then we have to then start doing a more extensive lymphatic kind of excision to try to gain access and get rid of all that cancer. But by me cutting into that lymph system, I now am going to have problems with that drainage of that lymphatic system, and that's going to lead to the lymphedema. And you see in these pictures kind of the classic examples of complications from surgery and radiation therapy. You can see with the patients with the upper extremity version, this is probably in the setting of breast cancer treatments. So how do you treat this? Because we can't necessarily prevent it from happening by our surgeries if we're trying to do like cancer treatments and stuff. But what can we do once they have been diagnosed with lymphedema? Let's do compression devices, compression stockings or whatever. Skin hygiene is important. Exercising, so maybe like doing like the arm bike or the hand bike, so they're pedaling with their hands. And then maybe they need to be undergoing regular like massage to try to encourage that lymphatic drainage so it doesn't just pool in that extremity. So do what you can to try to prevent, decrease that space that fluid can accumulate and encourage that drainage out of that extremity and back up to the heart. Questions about that? So that is the end of my new material lectures. Let's go ahead and take our 10-minute break, and then we'll come back and start the review for our review for the next 50 minutes for our test. So that way we can make sure that we get through all of our review slides within the dedicated time for the class. So this block, basically we're looking at the vascular diseases. And to talk about vascular disease, you have to know what are the risk factors of vascular disease. So we talked about hypertension starting off first. And we talked about how there's different classifications of hypertension, and I'm testing you using the ACC-AHA guidelines. So make sure you know what those guidelines are. Okay. Don't worry about the JNC and don't worry about the ISH guidelines. Just focus on the ACC-AHA. So what's stage 1, what's stage 2, those kinds of things. Also remember that one isolated elevated blood pressure does not mean you have hypertension. You have to have at least 2 to 3 abnormal values on 2 to 3 separate occasions to be able to be diagnosed with hypertension. Okay? There's primary and there's secondary hypertension. Primary basically means we don't have any other identifiable cause for it. So it's just kind of a catch-all. Secondary is that there is something else that is some other pathology that's going on where the hypertension, the high blood pressure is a symptom of that condition. Okay. Then we talk about white coat hypertension, this is a patient who comes into the medical clinic and will have that elevated blood pressure, but when they're at home, it's normal. We talk about masked hypertension, which is the opposite, where now that blood pressure is normal in the clinic, but it's abnormal when they're at home. And then the last definition we talked about was a resistant hypertension, which is this is a patient who is taking all of their meds, they're on at least 3 medications, and they are compliant, but they continue to not meet goal. So usually there's something else maybe we should be doing for that. And then just remember that there are factors, potentially modifiable factors, that can contribute to a false elevation of the blood pressure. So for instance, having a full bladder, not using the proper cup size. Things that we can do or afford the opportunity or a patient to actually get a more accurate blood pressure reading for them. For our folks with white coat hypertension or folks that are difficult to diagnose, our ambulatory blood pressure monitoring system is an option, and it is the most accurate way to diagnose somebody with hypertension. Because basically they go about their normal day and we just are taking the blood pressure over the course of a 24-hour period of time, and then we can download the data to see where their blood pressures were, to see if they actually do qualify for a diagnosis of hypertension. The USPSTF does have screening recommendations, so 18-year-olds and older should get at least 1 blood pressure screening, and then every 3 to 5 years afterwards if it's normal and they're low risk. When they get to 40 or they are high risk, meaning like obesity, African Americans, then they recommend an annual screening for those folks. When you do your assessment on somebody who has elevated blood pressures, yes, go ahead, take history, do a physical, looking for maybe causes of like secondary hypertension or other risk factors that may cause them to have hypertension. But you're going to want to get a baseline set of labs to help with the diagnosis and the management of this patient. So this is going to be your standard panel of tests that you're going to do for a patient with a new diagnosis of hypertension. Let's manage the risk factors from a primary hypertension standpoint. Let's manage the risk factors to include physical inactivity, obesity, other comorbidities, smoking. Let's try to treat those things to decrease that risk or even potentially bring down their blood pressures to a more normal range. So lifestyle stuff is important. There's lots of, so the equation for blood pressure is this. I'm not going to tell you, I'm not going to ask you a math question. But just remember that the blood pressure management is a tightly regulated system where there's all these different steps where you can increase the blood pressure, but you can also have areas where you decrease the blood pressure. But the body is more concerned with increasing that blood pressure. There's more opportunities to increase that blood pressure than there is to decrease it. Now, when we talk about our goal, according to the AHA-ACC guidelines, it is recommended, of course these are the old goals, it is recommended that folks who have a 10-year ASCVD risk of 10% or higher, that the goal should be their blood pressure is 130, less than 130 over 80. If their ASCVD risk is not more than 10, but it's less than 10, then it's reasonable to kind of get them less than that 130 over 80, but that's not something you have to do, okay? Talk to your patients. When we talk about treatment, there are the non-pharmacologic lifestyle things that can be done, to include doing a DASH diet pattern, which tends to be the best. If you had to do one of these things, it is the best at lowering your blood pressure. But there is the weight loss, there is the increased physical activity, and there is also the moderation in alcohol intake. All of those things can have a synergistic effect at lowering your blood pressure. And maybe they don't even need to be on an antihypertensive if they observe this. Smoking cessation is important because you get that transitory increase in blood pressure with nicotine. Stress management stuff is important because stress leads to that overdrive of the sympathetic nervous system, which causes the vasoconstriction, which causes the increase in blood pressure. So trying to manage that stress appropriately is important. Caffeine reduction at least has a transitory reduction. But your DASH diet isn't going to be important, so just eating more fruits, eating more vegetables, eating lean proteins and stuff like that. But when it comes to pharmacologic therapy, our first-line agents are typically going to be one of 4 categories. So thiazide diuretics or thiazide-like diuretics, ACE inhibitors or ARBs, and then your calcium channel blockers are going to be our primary first-line agents. When we talk about our first-line agents, of course, ACE inhibitors work by blocking the conversion of angiotensin 1 to angiotensin 2. So that prohibits that angiotensin 2 from going and having that direct vasoconstrictive effect on the blood vessels. It also goes to the adrenal gland where it blocks the secretion of aldosterone, which then leads to that increased reabsorption of sodium and water in the kidney, leading to a decreased volume of blood, which leads to a decrease in your blood pressure. But we also talked about how ACE inhibitors have an additional advantage to help lower blood pressure by preventing the breakdown of bradykinin into these inactive peptides, and leads to more of an elevated nitric oxide value or levels in the blood. And that nitric oxide has a direct vasodilatory effect, so it lowers blood pressure that way. So ACE inhibitors have that other additional benefit to it. Now the ARBs work very similar to ACE inhibitors. It's just, of course, now at one level down, where instead of preventing the angiotensin converting enzyme from breaking angiotensin 1 and angiotensin 2, it blocks the receptors of angiotensin 2 so that the angiotensin 2 cannot have an impact causing that vasoconstriction or the release of aldosterone. It does not do anything for bradykinin levels, so that's why we tend to reserve ARBs for those who have the cough side effect for ACE inhibitors, because that cough is coming from the bradykinin level being higher than normal. ACEs and ARBs, absolutely contraindicated in somebody who is pregnant. You've got to switch them to some other agent that's approved, which the ones that are approved are methyl-dopa, nifedipine, labetalol, or hydralazine. And they'll have that for the full duration of their pregnancy. And the reason that these are contraindicated is because there is documented fetal injury that can occur. Okay? Doesn't necessarily affect the mother, it's the developing baby that will be impacted by this medication, these classes of medications. And then the side effects, Cough being kind of one of the main thing that distinguishes ACE inhibitors from the ARBs. Then we talk about thiazides, and we talk about how they worked. And these work great. They help reduce strokes and major cardiovascular events. You get a good clinical effect from these agents. They even work great for folks who do have some kidney function issues, but you just have to be careful if that kidney function deteriorates to below 30, then you've got to change them up because it doesn't really have as much of an impact or effect anymore. The one big thing that you have to be careful about thiazides is the electrolyte disturbances that can develop from this. So you've got to watch those electrolytes closely. Folks who have an issue with gout already should not be put on a thiazide diuretic because it can cause the uric acid levels to rise, which then can precipitate recurrent gout flares. So if you have a patient with gout, don't put them on this agent. Then not a primary or first-line agent, but we did talk about potassium-sparing diuretics like spironolactone, and we talked about how these work. And these aren't great as an antihypertensive unless there's a specific condition in the secondary hypertension that it would work better at. But be careful of using these for the off-label kind of uses. So things like in patients with PCOS, trying to manage those antiadrenergic effects from it. Women with resistant acne, they be put on this to kind of treat that antiadrenergic stuff. And then, of course, being careful of hyperkalemia if you're prescribing this and you're on ACE or an ARB. Calcium channel blockers are an additional great first-line agent, particularly when we talk about the dihydropyridines at lowering blood pressure. They work by preventing that calcium inflow, so you don't have that elevated or those calcium levels high. So the smooth muscle cells inside of the vessels are less likely to constrict because they don't have the calcium necessary to cause that. So that's how they work in lowering the blood pressure. It kind of prevents that vasoconstriction. Works great even in the elderly patients. There is some electrolyte disturbances with it, but the ankle edema or just edema in general is one of the more common side effects that causes folks to want to switch off of this antihypertensive. Additional agents that, although not first-line antihypertensives, you have to be careful when you do prescribe these to patients for other reasons, and what it can do to the blood pressure include like our alpha-1 adrenergic blocking agents, because our elderly male patients with BPH, you put it on, give them that medication, it could cause their blood pressures to drop too far, and now they're experiencing syncopal episodes from that. Alpha-2 agonist, not a primary or a first-line agent because of the side effects associated with this. However, in the correct clinical condition, these are indicated. So methyldopa, we talked about, is indicated for pregnant patients with hypertension. So that would be an indication to prescribe this. Unfortunately, they just are going to have to experience these anticholinergic effects from that. Beta blockers, these do have some effect on blood pressure. We don't usually use these as first-line agents because it has more of a cardiac, like heart rate and contractility effect. But labetalol, the labetalol version of beta blocker actually has a more profound effect on blood pressure. But just being careful of putting these on patients who also are on other antihypertensives. Side effects are associated with beta blockers, so just be careful of those. The hydralazine, which is a direct-acting vasodilator, limited use, not a primary agent, but in conditions like pregnancy, conditions like hypertensive emergency, these are indicated and can have a good benefit, but not something that we typically use for primary first-line management. Then when we talked about management, it kind of depends on what our ASCVD risk is for our patient. There are certain populations where one medication may be absolutely contraindicated, or maybe there's a patient population where we should probably consider other things because of the clinical effect that happens in that population. When we have patients who have hypertension and they have chronic kidney disease, then it is highly recommended that one of the agents they are on is an ACE inhibitor. If they can't tolerate ACEs, then let's put them on an ARB of some sort. And then this is just a summarization slide of the different agents and the different electrolyte abnormalities that could develop because of that antihypertensive. So we just need to monitor these closely if our patients are on any of these medications. And that was our primary hypertension lecture. Secondary hypertension, so now there is an additional pathology that is present that's causing the symptom of hypertension. And typically you're going to associate this in patients who have hypertension developed prior to the age of 20 or over the age of 50. If they have it where all of a sudden their blood pressure increases instead of it being a gradual process, then be concerned that they have a secondary etiology. If it's abrupt onset, that might be something. If there's other physical exam findings of other disease present, then be concerned for this. Then we talked about the different causes. We first talked about renal causes of secondary hypertension. And when we talked about the problems with the vessels going to the kidneys, the two types were fibromuscular dysplasia, which tends to be in younger women, although that's the less common version of it. But then we talked about renal artery stenosis, which is the much more common version of this, where you typically see this in elderly males who have atherosclerotic plaque development. So think of the risk factors for atherosclerosis are going to be your risk factors for developing this condition or this etiology of hypertension. And the reason that these patients have it, the physiology involved, is the kidney perceives that there's reduced blood flow coming to it. It tries to go in self-preservation and thinks that all of the organs are experiencing this. So it causes the renin to be released, which activates that RAS system to increase your blood pressure. The second version of renal causes is instead of the blood vessels to the kidneys that are the problem, it's actually the kidney itself. So the nephrons, the filter part, is the problem. Things like diabetic nephropathy, where the damage to the filter occurs, and that leads to a reduction in the glomerular filtration rate, which then leads to that self-preservation response, and it activates the RAS and elevates the blood pressure. But what kind of differentiates these patients from the patients that we talked about on the slide before is because the GFR is impacted by this, because that filter is damaged, these folks are going to have that abnormal urinalysis and they're going to have abnormal kidney function. Okay. Know how the RAS works, so what is involved, so know that. Because that's important to know, because when we talk about hyperaldosteronism, this RAS is important because that aldosterone causes the kidney to reabsorb sodium and water, increasing that volume, which then leads to the increase in pressure. But that's all done at the expense of potassium, and you start to you start to secrete potassium inappropriately in the kidneys. This, although traditionally is considered less common, with new studies, new abilities to test for, and of course with the new guidelines, we're seeing that this is actually a lot more common than we think it is, and that this is actually in new literature studies becoming the most common cause of secondary hypertension. Typically, patients or things that should make you suspicious for this is going to be your hypertensive patient who happens to have hypokalemia. So if you see low potassium levels in a patient with hypertension, definitely be thinking of this. To help you diagnose this, you can do an elevated, you can do a 24-hour urine aldosterone level, and that will be elevated because you're secreting all this additional aldosterone inappropriately. Or you can do a serum aldosterone to renin ratio, and that would be elevated. Then we talked about Cushing's syndrome, where you have this excess glucocorticoid, so like cortisol, being secreted, and that can then have the secondary impacts of raising your blood pressure. The way we diagnose this is we give a dexamethasone suppression test, and then we draw their blood a period of time after the administration of the dexamethasone, and we see that the cortisol levels remain elevated. Another test would be a 24-hour urine cortisol level. So you just collect the urine, check for cortisol levels in there, and that would be elevated as well. But you can see when you have somebody with Cushing's syndrome, there's going to be physical exam findings associated with this condition. So we usually talk about like the buffalo hump. We talk about the red stria on the abdomen. It's got easy bruisability, thin skin, poor wound healing, moon face. All that can be associated with this condition. So if you have somebody who kind of fits the physical exam findings of this, then look for Cushing's disease. Then the last like adrenal cause of secondary hypertension that we talked about was pheochromocytoma, which is very rare. However, standardized tests love to test on this. And this is due to a catecholamine secreting tumor. So you get your epinephrines and those kinds of things being secreted inappropriately from these neuroendocrine cells. And typically what you're going to have is this classic triad of this episodic headache with sweating and tachycardia. So you're stimulating that sympathetic nervous system inappropriately from all of these neuroendocrine cells releasing the catecholamines. And the way you diagnose this is doing a 24-hour urine fractionated catecholamines metanephrines test, and you can see it's very accurate in the diagnosis of this. And typically, you're going to see this tumor in the adrenal gland. However, if you don't find it on imaging, then it could be really anywhere on like the sympathetic chain. So you may need to do like a head-to-toe kind of imaging study to look for that neuroendocrine tumor if you have somebody with a pheochromocytoma. Then we talked about coarctation of the aorta, which we talked about in our congenital heart disease lecture. But this is going to be your patient with systolic hypertension in the upper extremities, where they may have a low or normal blood pressure in the lower extremities because of that narrowing of the aorta. You may see rib notching on chest x-ray as the collateral blood flow is trying to find a way around that coarctation or that lumen narrowing. Then we talked about endocrine causes of secondary hypertension. So hyperthyroidism causes a systolic hypertension, and then hypothyroidism causes a diastolic hypertension. And then hyperparathyroidism can cause secondary hypertension because now you have elevated levels of calcium, and that elevated levels of calcium can then go to the smooth muscle cells and cause that vasoconstriction inappropriately. And then we also talked about how sleep apnea can lead to hypertension, maybe because of like cortisol being released from that chronic kind of stress of hypoxia. So treat those patients' sleep apnea and their blood pressure control will get much better. Other medications that can lead to this. And then, of course, other toxins like alcohol, cocaine, and amphetamines can also lead to hypertension for various reasons. But when trying to manage hypertension, patients may be resistant to start because they don't feel symptomatic from their elevated blood pressures. This is where we have to have that conversation of what life is going to look like in the next 10, 15, 20 years from now, because consequences and complications will develop from poorly controlled high blood pressure. You're going to have increased afterload, which then can lead to things like heart failure or even a heart attack because you're having an increased oxygen demand. Then you can have damage to the arteries, which then can lead to a bunch of other things, including heart attacks, aortic dissections, and aneurysms, strokes, kidney failure, and even blindness. So this is the conversation that you're going to have with your patients who are hesitant to start medications because they don't feel like they need them. Then we talked about hypertensive crisis, and the definition is having that systolic greater than or equal to 180 and a diastolic of 120 or higher. We talked about how there's two flavors to hypertensive crisis. There's hypertensive urgency, which is you have that severe elevation, but there are no symptoms. Headaches, stacks, bloody nose, and vagueness, those don't count as symptoms of end organ damage. And when we have somebody who falls into this category, we typically are not as aggressive at lowering the blood pressure. We have a couple of days to get them back down to a more normal range. However, if we have a hypertensive emergency, which is you have that severe elevation in blood pressure and you have end organ damage, then we have to be extra aggressive in lowering their blood pressure because those organs are undergoing significant stress and potentially dying if you weren't to get that blood pressure under control. And the symptoms of end organ damage that you may encounter kind of depend on the area that's affected. So if we're talking about like the brain central nervous system, okay, it makes sense if you have unilateral weakness, sensory changes, altered mental status, delirium, seizures. All of those are symptoms that the brain is suffering from that blood pressure being too elevated. From a cardiac standpoint, okay, they're going to have that ischemic chest pain, they're going to have pulmonary edema, things that show like the heart is in failure because of that blood pressure being so far elevated. Kidneys, you're going to see kidney function deteriorating, so BUN and creatinine levels are going to go up. From a vascular standpoint, you may, like, especially if it's like aortic dissection, you're going to have symptoms of that tearing. And then the eyes, you're going to see retinal changes associated with it. So be on the alert for that when you encounter somebody with that profound elevated blood pressure. If your patient is a hypertensive urgency, then we typically use oral medications to lower their blood pressure within a couple of days. Typically what leads to hypertensive urgency is these folks should be on medications and they became non-compliant for a reason. So we just need to restart their medication, their home medication, and get their blood pressure under control. If you have a hypertensive emergency patient, you're going to admit them to the ICU because you're going to have to do some pretty invasive monitoring, so arterial lines to monitor their blood pressure, and then you're also going to be giving them IV antihypertensives to control their blood pressure. I can't rely on that blood pressure cuff going off every 15 minutes to manage these patients. When it comes to pharmacologic therapies in an IV form that we can use to treat our patients, be thinking of like labetalol, nitroprusside, or nicardipine as being kind of your best options in treating this. But when you look at the AHA-ACC guidelines in the management of hypertensive crisis, and you have somebody who has a hypertensive emergency, the first thing you need to ask yourself is, do they have another condition like preeclampsia or pheochromocytoma? If they have one of these conditions, then within the first hour, I'm going to be more aggressive in lowering their blood pressure to less than 140, and then I'll continue thereafter to try to lower it. If they have aortic dissection, I have to get their blood pressure less than 120 in that first hour. You can see that in this box right here, just to verify what I'm telling you is accurate. If they don't have one of these conditions, then the way you treat your hypertensive emergency is in more of a stepwise fashion. So within the first hour, you want to drop their blood pressure by no more than 25%. Okay? You want to reduce that blood pressure so that those organs that are becoming damaged from that blood pressure elevation will stop becoming damaged. And then after you've done that reduction, bring them down to 160 over 100 within the next 2 to 6 hours, and then cautiously bring them down to normal over the next couple of days. Okay. If you have aortic dissection, we talked about being very aggressive in lowering their blood pressure within that first hour, and the agents that we typically will use are first morphine. Bring down that pain that they're experiencing from that tearing, and maybe that's all that's necessary to get their blood pressure down to that 120 or 110 kind of range. If they need additional agents, then be thinking like your beta blockers like labetalol or esmolol to further help reduce that blood pressure to goal. If you have somebody who is experiencing a hypertensive crisis because of cocaine or amphetamine, we're not going to give them beta blockers because then you can have that unopposed alpha stimulation. So we're going to give them benzodiazepines instead. So give them lorazepam or diazepam to manage that and get them through that sympathetic crisis from the drugs. If you have an acute myocardial infarction, this is not one of our specific conditions, but nitroglycerin may be all that we need to get their blood pressure to drop that 20 to 25% in that first hour, because you also then are treating the infarction as well. So do that as your first line and then add to it if needed. And that was our blood pressure. Then we moved on and we started talking about atherosclerosis and lipid disorders. And we talked about how there's modifiable risk factors for atherosclerosis where we can actually intervene with our patients to make them healthier and hopefully prevent them from developing atherosclerosis in the first place. But there are non-modifiable risk factors that we can't change that unfortunately put those folks at a high risk or higher risk of developing atherosclerosis. And then we talked about how the anatomy of the artery, you've got the intima as the innermost layer, you have the media, and you have the adventitia, and basically, the endothelial layer of the intima is kind of what controls the inflammatory kind of reaction that then could lead to the development of atherosclerosis. And it works by that where you initially get this fatty streak formation that then progresses to a more complex plaque that then leads to potentially having a portion of that plaque break, and then it causes the formation of a clot in that area. And when we look at the fatty streak, this is where that initial lipid LDL deposit occurs that then triggers that inflammatory process, which then leads to the monocytes coming in, turning into macrophages, and they start eating all this LDL, but they have no ability to digest it, to get rid of it, and they just become more and more engorged and bigger. They become these foam cells, and then they rupture, which then releases all these inflammatory compounds that then further leads to more inflammation. That then triggers the plaque to progress to a more complex structure because that recruits smooth muscle cells to come in to kind of surround and wall off this area because it recognizes that this is a foreign thing and it shouldn't be there, it's causing problems, which then leads to the body being like, okay, this shouldn't be there either, so let me start breaking this down, get rid of it, and you kind of get this battle between the two systems that then can lead to plaque disruption. which then can lead to that acute occlusion or development of a blood clot and occlude and block that blood vessel. Then we talked about how there's certain definitions associated with lipid disorders. And it's important when you're using these terms to kind of understand what you're trying to communicate, okay? So dyslipidemia, if you use that term, is your LDL is high, but your HDL is low. When you say hyperlipidemia, what you're saying is that the LDL is high and the triglycerides are high. You say hypercholesterolemia, you're just saying that the total cholesterol is elevated. And when you say hypertriglyceridemia, it's your triglyceride levels are elevated. Then when we started looking at the etiologies of hyperlipidemia, there are the primary things, which are genetic disorders, and then there's the secondary things, which is there's usually something else going on leading to the development of those atherosclerotic plaques. When we talk about primary genetic disorders, we talk about one version is familial hypercholesterolemia, where there's an LDL receptor gene mutation that leads to that elevated LDL even in childhood. So these folks are at a much higher risk of premature cardiovascular disease. They're having heart attacks in their 30s, 40s, and those types of things. Then there was the familial combined hyperlipidemia, which is a triglyceride and LDL problem. And these folks also have premature cardiovascular disease formation and could be pretty young when they start having symptoms from this disease. From a secondary cause, secondary causes of hyperlipidemia, just think of like the things that lead to being unhealthy, leading to that, and maybe we need to modify some of the lifestyle choices in order to treat and manage this. Now, for folks who have pretty profound elevations in their LDLs, there actually may be some physical exam findings that we can see that would make us even more suspicious of them having elevated cholesterol. Examples of this are xanthomas, which there's 3 types to that. There's xanthelasma, and then there's the corneal arcus. Or xanthomas are eruptive xanthomas, which is just kind of like these little yellowish dots that develop on surfaces like the buttocks, the back. That it almost looks like acne, but instead of it being erythematous and full of whiteheads, this is more of a yellow kind of appearance to it. You can have a tendinous xanthoma, which are these firm nodules that develop on the extensor surfaces of the hands or the Achilles tendon. You have a tuberous xanthoma, which are yellowish nodules that appear on like the elbows or the knees. And then those were our xanthomas. Our xanthelasma is this yellow deposition of cholesterol basically around the eyes. And that could lead to you being suspicious for cholesterol issues. And then corneal arcus is that deposition of yellow around the cornea. And that is cholesterol deposition. That's not copper deposition like you get with Kaiser-Fleischer rings in Wilson's disease. When you have a patient who you suspect has elevated LDLs, what are you going to do? Well, let's do lipids, and let's verify that they are in fact elevated. And then let's do some additional labs. So let's do like a complete metabolic panel to assess liver function, because statins can interfere with liver function, right? So let's do that. Let's also check kidney function. And then also let's check your hemoglobin A1C, because that's going to help us in the diagnosis with our ASCVD risk. And then, of course, let's get our creatinine kinase a baseline, because statins can cause an elevation in your creatinine kinase levels if there's a side effect associated with that. Then you have your lifestyle changes that you can talk to your patient about as far as helping to reduce your cholesterol levels. So exercise and eating healthy, you can see, has both a profound impact on the LDL, but also the triglyceride levels as well. And then we talked about how statins are our best oral medication for reducing LDLs. They have a great clinical effect to them. There are side effects, particularly when we think of like the muscle problems. So they may have just muscle pain, but they could have a more serious condition, myopathy, where there is muscle breakdown, where they start to have that elevation in creatine kinase that's above normal. But then an even worse version of this is rhabdo, where you have that profound elevation in creatine kinase, and you have serum creatinine elevation. So there's kidney damage that's occurring from this condition. And then we talked about how if the patient's having severe muscle symptoms, stop or discontinue the statin, work them up, and then kind of making a determination on next steps as far as treatment with their cholesterol. If they have mild to moderate muscle symptoms, then you're going to discontinue the statin while you work them up. Look for other conditions that may put them at a higher risk of having a reaction to statins, so things like hypothyroidism or vitamin D deficiency. If that workup is normal, or you start to treat those conditions, then and the symptoms resolve, go ahead and maybe start on the same dose of the statin, or the same statin, change the statin up, or even give them a lower dose. But this does not mean that they have a permanent insensitivity to statins or an allergy to statins. And then when you talk about statin therapy, make sure you know what dosages of each medication give you a high intensity and moderate intensity. What differentiates these two dosages is I expect a greater than or equal to 50% reduction in LDL with a high intensity. I expect a 30 to 49% reduction in LDLs with a moderate intensity dose. And don't learn these ones. Nobody uses those. If you have a patient who is not getting to goal with a max dosed or max tolerated dose of statin, then you can add ezetimibe or Zetia to your treatment regimen. And this works differently from statins in lowering your cholesterol by blocking that absorptions of cholesterol out of the intestines. And this is a great adjunctive therapy. It's not really a great monotherapy agent in lowering your cholesterol levels. For patients who cannot tolerate a statin, or they're on a max dose statin and they're on ezetimibe and they're still not getting to goal, then your PCSK9 inhibitors are an option to treat these patients. It's usually pretty well tolerated. It's just very expensive. But these patients, when you do give it to them, they tend to have a pretty good response to the lowering of their LDLs. And then when we talk about management guidelines, the first step in determining what our goals are is determine, is this a patient who has primary prevention, meaning that we're trying to prevent them from having an atherosclerotic cardiovascular disease in the first place? Or is this somebody who had an atherosclerotic cardiovascular disease and now we're trying to prevent it from happening again? And that would be a secondary prevention. And then I'm going to give you this algorithm to review during the test. And you can see kind of how you fall down on this algorithm and what our initial therapy should be and what our goals should be depending on which category our patient falls into with this. And then we talked about how there are like risk enhancers. So there's a number of things. So if they have other comorbidities, they have a family history of premature cardiovascular disease, that's a risk factor. If they have metabolic syndrome, then that's a risk factor. You may need to be a little more aggressive in management of their cholesterol. And then we talked about how when you're looking at a secondary prevention treatment protocol, you've got to determine if this person is in a very high risk ASCVD or if they are in a stable ASCVD category. And what differentiates that is somebody who is considered very high risk is they have 2 or more of these, so they have had a heart attack, they've had a stroke, or they've had a heart attack, and they have symptomatic peripheral arterial disease. Or they have one of the major risk factors, and then they have at least 2 of the high-risk conditions. So they have other comorbidities that puts them at a higher risk. And that's going to determine which leg of the algorithm you go down to, what your goals are, and all that kind of stuff. Then to finish up today's lecture, we talked about hypertriglyceridemia. We talked about how you're considered to have moderate hypertriglyceridemia if your values are between 175 and 499. Ideally, normal is less than 150. And then severe is if that value is now greater than 500. And then when we looked at the actual treatment protocol for it, yes, there are the lifestyle choices there. But for moderate elevations of triglycerides, we usually just do lifestyle changes. There's no medications necessary or necessarily indicated to treat this condition. When we have severe elevation, this is where we actually will give medications specific to treat the triglyceride levels, which there's a number of things, but the fibrates tend to be the most beneficial at lowering triglyceride levels. So when we talk about fenofibrate, you're looking at about a 35 to 50% reduction in your triglyceride levels. Gemfibrozol has a better reduction, but unfortunately, when you combine that with statins, it tends to increase the risk of rhabdos. So never combine gemfibrozol with patients who are on statin therapy. This is just how fibrates work. They work great at lowering triglyceride levels. Other options for us, so niacin can help with lowering triglyceride levels as well, but unfortunately they tend to not tolerate the side effects associated with it. Omega-3 fatty acids are also an option. We don't really know how it works. We just have seen that it does tend to lower triglyceride levels. And then we talked about metabolic syndrome again to finish up. You need at least 3 of these to meet the criteria of having metabolic syndrome. And that's where we're going to end today's lecture. Okay, so we'll pick up on Monday.